Hello friends, I am Dr. Sourabh Patwardhan from Nandadeep Eye Hospital, PG Teaching Institute and FECO SICS Training Center, Sangli, Maharashtra, India. In our center, we have a lot of teaching activities which includes hands-on training as well. In the previous video, I showed a case of Argentinian flag sign, and I would like to show what happened next after the anterior capsule was extended. So let's just recap the case. 18-year-old topical anesthesia, operated PP with silicone oil which was present, and there was an intumescent cataract. So there were some additional risk factors here. Now in case of a usual intumescent cataract, I either use two-stage Rexis or I use that 5 steps which I have shown in previous videos, and there is no risk of Argentinian flag in those cases. But here, because of the additional risk factors, there was high chance of Argentinian flag, and despite using the heavy dispersive OVD, when I touched the anterior capsule using the forceps, immediately it ruptured, and it didn't give me much of time to react. So the moment I touched the capsule, within 333 milliseconds the capsule ruptured till the equator, which is within a blink of an eye. So let's see what were the additional risk factors. Young patient, elastic sclera. Apart from that, there was silicone oil in the vitreous cavity. That means that it was pushing the lens anteriorly, which is an additional risk factor for the extension of the CCC. And if you see the video again, I think there was OVD leak because of use of the larger main incision and use of a larger forceps rather than micro forceps when I started the capsule Rexis. So I could have tried it through a small side port incision, and of course it wasn't topical anesthesia and might have been more pressure due to muscle tone and the eye movements which were happening. Now once it happened, I decided to enlarge the anterior capsule tear a bit so that there is more space for me to remove the lens matter. So I have kept my Sinski inside so that the eye movements are not there. It's a very soft cataract as I expect, so it's only aspiration of the lens there. It's very soft, so it comes out very easily. Now there is already a heavy dispersive OVD inside, so that helps in maintaining the chamber as I remove my phaco probe, but other approach can be pushing the OVD from the left side port while I remove the phaco probe. And the single piece IL is now inserted, making sure that once it goes into the bag, it's carefully nudged in such a way that the haptics stay in the area where there is no tear. So that gives quite adequate support to the IOL, and I am sure that this IOL will be stable for long time. I don't expect any decentrations in this case. Once the IOL is in place, I decided to just open the anterior capsule a little bit more, so we don't have the anterocapsular fibrosis in the pupillary area. So I made a cut using the micro scissors and enlarged that area, followed by removal of the OVD. So overall there was not much of a challenge in the case even after I got Argentinian flag sign, and it went without any further event. This was just 3 months back operated. You can see with silicone oil in situ there will be some fibrosis of the posterior capsule which sets in, as you can see here. After removal of OVD, the wounds were nicely hydrated and the case was over. So in most of the cases where Argentinian flag sign appears, the surgery can go just as planned, and you can place the single piece IL in the bag as well very easily. For more such videos, you can join the YouTube channel, and we have a lot of playlists. I have many edited videos, also teaching videos in this playlist, so do subscribe and watch. Thank you.